All right, let's jump right in. Can you introduce yourself for the tape?
Hello, hi, my name is Dr. Maria Loco. I'm a board certified urologist that specializes in comprehensive sexual health, which means that I take care of the medical and surgical management of sexual dysfunction for all genders. And I believe that there is a silent public health crisis happening in women's healthcare today.
All right, well, that is a really important place to start. So, can you tell us a little bit about that silent epidemic?
Yeah, I started medical school at 17, and then became a board certified urologist. And then in 2020, I did a fellowship in comprehensive sexual health, which was essentially learning about male sexual health, female sexual health, and kind of everything in between. And I realized that I went through almost 15 years of medical education and training and never learned a lot about women's bodies and
Mhm.
vulvar anatomy and physiology, like even the basics of anatomy and physiology, which are the basics of medicine, we never truly learned, despite being a urologist, that is in the vulva, that is taking care of your bladder, which is part of the female pelvis. It was that eye-opening moment where I realized, like, whoa, if I didn't learn this and I'm in this particular field, who else isn't learning this? And so that got me really deeply curious about how we teach and train medical education around women's health, women's bodies, women's research. And I've been on a mission ever since to close the gaps between gendered care.
And why do you think this disparity exists? Why don't we spend enough time thinking about and learning about women's reproductive health and anatomy generally?
Yeah, I think it stems from so many things, right? There's a pay inequality. So if you think about how you are getting reimbursed as a physician, you're going to get highly reimbursed or better reimbursed if you are doing obstetrical care in women's health. So obstetrical care has better reimbursement rates. It also has higher litigation rates, and gynecologic care, which essentially has been relegated to things like UTIs and pelvic pain and infections, a lot of quality of life metrics, which historically medicine has never really centered women's quality of life, kind of fall into that, and it has poor reimbursement rates. And then if we take a look back too, I mean, medical sexism is a real thing. As someone that is able to take care of all genders, especially looking at it from a sexual health lens, exists a huge divide in how you can access care. Your genitalia directly impacts your health care. And I think a lot of physicians don't realize this. I didn't realize this until 2020. I didn't know what I didn't know. And I think that's the issue for many doctors. We don't know what we don't know. We oftentimes go into medical education, we pay a lot of money, we take a lot of tests, they tell us we're the best of the best, and so we have this trust that the system will teach us everything that we need to know. And we're going to come out of this training knowing everything that we need to know. And then we actually get into real medical practice, and conditions like menopause, pelvic pain, recurrent UTIs, we're never really taught those conditions in medical school, in medical training, in medical education. And so then when we're in the real world taking care of these patients, we are oftentimes highly misdiagnosing them and causing or saying things are chronic, diseases that are chronic that aren't actually chronic, but we're really just keeping patients stuck in a cycle of re-diagnosis and misdiagnosis. And so, I think many systems are at play, an economic system, a system of inequality when it comes to sexism. There's just so many systems that are at play. And I think really the biggest one is that all doctors take the Hippocratic Oath of first do no harm, and we don't realize the harm that we're doing because we also are just not aware that we're not getting the education.
Yeah, I think a lot about there's a space between physiology and pathology. And there's a whole bundle of challenges and states of being that sit between those things. Like this is clear pathology or this is just physiological. And states of discomfort that are not readily identifiable as pathology as a function of what we actually identify as pathology. And what happens is because we don't think a little bit about that space in between and ask, what should we know about this? And
Mm,
how can we identify ways to make somebody more comfortable when they sit in this state? And because we don't necessarily have clear names for a lot of the things that we might identify, what tends to happen is a lot gets packed in where somebody has a challenge and it's something that's causing them pain or dysfunction. But because we don't necessarily name it the right thing, or investment hasn't been put into figuring out what its name is and how to treat it, we just sort of bundle it as physiologic. And so
Hmm.
we tell people that they should just live with this. It's just a function of inhabiting a body. And there are things that are that way, but often when you ask who then has to live in that space more often, it tends to be women, it
Hmm.
tends to be people of color, and it tends to be folks whose issues tend to get marginalized out of what we study as being a serious illness. And then the other part of that is you've got things that are actually just normal physiology that people pathologize. So I think about like Peyronie's disease, right? Peyronie's disease is not, I don't know, I don't think of it as a disease. It's just a penis that's not directly straight, right?
Hmm.
And I think for some men that may cause some discomfort, but there's not a clear set of symptoms aside from, I don't know, dude looks down and is like, yeah, I don't know, I don't love the shape of that, right? And then we've literally called it a disease and then created all kinds of treatments for it, right? Whether they're
Yeah.
surgical or now medical. And so you think about then, this is like normal physiology that then gets pathologized, right?
Hmm.
And why? Because you're talking about an issue that a man may find discomforting that doesn't actually necessarily cause pain or dysfunction.
Yeah.
And it's just such a like a helpful tool to sort of think about, okay, what gets ignored versus what gets pathologized. I'd love to hear about, some of the consequences of how our failure to take on the challenges that arise from our failure to name the discomforture and the pain and the dysfunction that arises from our lack of knowledge about female genitalia
Hmm.
and what that then means for patients.
Yeah, it's so interesting. Prior to this fellowship, I really had no interest. If you told me that I would become a pelvic pain specialist or UTI specialist, I would have laughed in your face. I wanted to do surgery to, fix a problem, see a problem, fix a problem. And, the adage or kind of the widely accepted attitudes in healthcare is that, issues like pelvic pain, issues like recurrent UTIs, they just are, it's just kind of something that's going to happen, and it's just something that you're going to have to deal with. And it wasn't until my fellowship when I realized that, oh, no, 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 there's research here, there's actual names for these things, there's actually ways to fix it, you can actually give people their life back. And the reason I care so much about this is if this pelvic pain was only affecting like a handful of people, I could have just done my work and been that advocate in that small group of people. But pelvic issues affect 1 in 4 people at any given point in time. And it actually, that number significantly increases when you go through perimenopause and menopause, which is something that will happen to everyone if they live long enough. It's one of those inevitable truths. And 84% of those people that are going through perimenopause, menopause, and postmenopause will have some sort of vulvovaginal condition, despite how prevalent these conditions are. It takes people 7 years to get a diagnosis. They see at least 3 doctors. 35% of people will see at least 15 doctors before they even get a diagnosis. That's not even saying treatment, that's just a diagnosis. And then treatment has such wide variations because people aren't doing a lot of spending a lot of time on diagnosis. When you actually know what you're treating, you have really high success rates for treatment. But because doctors are coming out of training without knowing anatomy, without knowing how the vulva should work then, and then not knowing then what is abnormal and why the vulva is abnormal, we are missing disease states like pelvic pain, recurrent UTIs, recurrent vaginal infections. These are conditions that affect 85 million people just in the United States alone. And if we think about globally how many vulvas there are currently 3 billion vulvas that are over the age of 18. And so that means that those vulvas are going to be impacted, and those vulvas being impacted are going into the world in a workforce that is largely uneducated about this. And I know this because we did a study that was just accepted and will be published later this year that actually looked at the current landscape of medical trainees in the United States. So people that are actively in residency, training to become specialists in their fields. We asked them, hey, what do you know about the vulva? What do you know about these conditions? All of the things. 75% of people and current medical trainees couldn't name the parts of the vulva, couldn't name the disease states of the vulva. This is it's a small study, it's a pilot study, but I think it's speaking to that larger narrative of our workforce of physicians are wholly untrained on vulvar anatomy, basic anatomy and physiology. And I care a lot about anatomy and physiology because, up until 2023, the clitoris, the actual clitoris we didn't know how many nerves are in the human clitoris. We didn't know how it functioned. And that was my research group that came up with that study. And that study literally came from the impact of not knowing anatomy and physiology. So many people will have surgery on their clitoris, and then they would get what we call iatrogenic injury, which is, the surgeons cut or injured the nerves, which then led to loss of sensation. And because we didn't know just basic anatomy and physiology, it wasn't until 2005 when Dr. Helen O'Connell, who was a urologist herself, created the first 3D model structure of the clitoris. This is wild because the penis, because I get to take care of all of these organs, has been defined since BC. Like Hippocrates, they have been, the great anatomists have been documenting these tissue structures. And they used to document the clitoris, but because the clitoris and female sexuality and his history and culture and all of those things, it made things such as anatomy and physiology, things that are just purely objective, you actually made it less objective because we're bringing in culture, and because culture has dictated that women's sexual beings gross. Let's ignore that. Let's not even address that anatomy, which is wild because these are bodies that are going to experience disease. And if we're just wholly not teaching medical trainees and medical doctors about these diseases based off of really antiquated ideas around sexuality, this is why we have currently UTIs, pelvic chronic vulvovaginal conditions are an $85 billion loss to the healthcare system as of today.